Thank you. Good morning. It's always a great privilege to be able to come to the Alzheimer Europe conference. This is, I think, the preeminent conference on dementia, probably anywhere, in terms of the quality of the content, but also just the engagement. This really feels an alive conference. It brings together people who are living with dementia, the people who care for them, their families, but also practitioners and policymakers, and it's genuinely an engaging event, so I'm always pleased to be able to join. I'm going to speak this morning about the second joint action on dementia. We're actually now into the final week of a 3.5-year programme. We conclude the joint action next week on the 30th of October. The European Commission helpfully a number of months ago gave us a 6-month extension to enable us to get the work done. And we are now able and confident that we will complete all the material that we need to do to be able to complete the joint action. The aim of the Act on Dementia Joint Action is to promote collaborative actions among member states to improve the lives of people living with dementia. And this is the intention, that the purpose of the joint action is about benefit. It's not simply about knowledge, it's not about expertise. The intention is that we are able to make improvements in the day-to-day lives of people across Europe who are living with dementia, and that's the standard and the test that we set ourselves at the outset of the joint action. And the method by which we do that is by giving practical guidance to policymakers developing and implementing their national dementia plans, policies and strategies, and also providing cost-effective and practical examples of core components of good dementia diagnosis, care and support. And I think that's important in that the way in which we are able to operate is by providing knowledge and expertise and experience. The work packages in the joint action, and those who have attended before have seen us present on this previously, are the first 3 work packages, which are largely about the structural delivery of the action. But then we have 4 work packages which are substantive and focus on key areas of change and delivery for dementia. And I'm going to say a bit about each of those and the work that's gone on within each of those. But before that, I think one of the things which I want to emphasize is in this joint action, we intended to take a different approach from previous joint actions that the European Union have funded, and that came, I guess, from a number of insights. The first is, generally, we actually do know what to do to provide high-quality care for people living with dementia. It's not a mystery. It's person-centered, it's engaged, it understands that people want to be able to continue to live normal lives, that they want to continue to be valued. It's about care, it's about compassion. So there isn't a great mystery about dementia care in much of the time. We did learn some things along the way as part of the joint action, and I'll come to the learning towards the end of my presentation. But again, within that, the learning that we got from the joint action, little of it surprised us. And again, this I think gives much of the challenge to governments and policymakers, that the world of dementia care isn't a mystery. The challenges that we do have throughout the process are, and I've said it here as the primary challenge for healthcare systems is not about knowing what to do, it's about implementation and change. And for that reason, in this joint action, the step that we took was to say that for much of the period of the joint action, we wanted to be testing best practice in locations across Europe to understand how to take change forward successfully and to understand better what the impediments to change were. So we wanted to know why it was that something which had worked in one part of Europe and had been then appeared as in a best practice guide or as evidence-based, why was it that wasn't appearing elsewhere in Europe? Why were the benefits of that not being delivered across Europe? Or if it was being implemented, why were people getting different outcomes? And I think this is where our shift needs to be. It needs to move from policy and strategy and commitments, and it needs to get into that space which is around delivery, because delivery is the point at which we get the benefits. We don't get the benefits when strategies are published. We get the benefits when services change and when lives improve. So I'm going to say a bit about each of the 4 substantive work streams and the sorts of programs that were within them. So the first is Work Package 4. And Work Package 4, which is about better diagnosis and post-diagnostic support, led by colleagues in France, in Lyon. In the first period of the work package, as with each of the work packages, they assessed the existing evidence. But then they went into a second phase in which they identified 3 key deliverables, 3 areas where they were going to take particular programs of work into locations. And these 3 are work on anti-stigma, work in primary care to change attitudes, work to improve support through giving expert advice to primary care doctors from specialist nurses, but also telemedicine. And these programs ran across France, Poland, and Bulgaria, and also in Italy. Sorry, the screen's quite a long way away, and my eyesight isn't really what it was. So we have work across France, and within this, I guess one of the ones to focus on in this is the anti-stigma work. And here what we saw was a program that focused less on providing knowledge and more which was focused around the attitudes and values that people held, and seeking to work in that context to change how people understood the experience of people living with dementia. So moving from simply knowledge transmission to actually understanding that what we were really looking for here was attitudinal change. In work package 5, crisis and care coordination, and this work was led by colleagues in the Netherlands and colleagues in Italy. What we focused on here, what most of the programs here were focused on, was the challenges around dementia in respect of behavioral and psychological effects. And within this, we saw action on the ground in Bulgaria, in France again, in Italy, in Modena, in the Netherlands, and in Scotland. And each of these areas took forward work which had been developed through the evidence base and took it into practice to see how it actually operated on the ground. The work within Italy, which is worth focusing on here, looked to identify how better community support could be offered to reduce the likelihood that people were hospitalized as a consequence of dementia. And it did so by offering specialist support, but also different ways in which people might receive care within the community. It focused on trying to find a different solution than simply hospitalizing somebody. In work package 6, we had a focus on residential care, led by our colleagues in Norway. And this understood that in many places across Europe, residential care is increasingly becoming a location which is primarily focused around support for people with dementia. And here we saw 6 different work packages, 6 different test sites on the ground, 5 of which were focused around improving knowledge and confidence within care staff in respect of how they would provide care. And one of which was in Norway, an e-learning process around understanding better palliative care. And here what we saw was in-depth approaches to try and deliver more skills, more knowledge. Within the challenge that across Europe, these are quite often workforces which change quickly. It can be work that people take for a period, and so it's an area where there continues to need to be an investment in training and time. Within this work package, we had 2 of the projects, the project in the Netherlands and the project in Norway, which were an attempt to move from something which had already been successful and which had already been tested and was being implemented, to understand the process by which that might be taken out at scale and rolled out as a national approach, as an approach which would then become the way in which care and support were offered. And the final work package 7, focused on dementia-friendly communities, and this was led by our colleagues in the United Kingdom, but involved programs of work across Greece, Bulgaria, and Italy. And I think this is an interesting program of work in that in the first year of the work, the report that was produced at that time by Diane Blood, and all of the reports are available, many of them are here with my team in the marketplace. It identified that often the idea of dementia-friendly communities was something that policymakers or municipalities did for other people. It was an idea, it was almost, it felt patriarchal, it felt as though it was a done to rather than a done with. And I think the important evidence that came out of the first year work on that was a need to rethink how we approach dementia-friendly communities. And what we saw within that was a more evolved model being developed, which had a greater focus on locality, was less cookie cutter, which was less stipulated, but understood that this would always be very contextual work, and it always needed to be taken forward in conjunction with people within the area who were living with dementia and their families. It needed to be built out of alliances and connections between different types of organizations, whether they were businesses or local public services or other types of organization, and that's where the richness and the change would come from. So across this, what we've seen is between 30 and 40 different actions on the ground during the period, the 3.5-year period of the joint action, probably just over 30 of which wouldn't have happened other than for the joint action. A number of the dementia-friendly communities which became part of it were already in place when the work began, but almost all of the other work that has gone on within the remit of the joint action was effectively new work delivered through that. So what we have is we have the action. In terms of the outcomes, and I would commend to you each of the substantive work programs has a short 16-page report, which is available. The team have them here. It's also available on the web. And it gives a good summary of each of the action and the focus. But I decided just to pull out a number of the core outcomes which I'd seen in terms of the particular deliverables. So we saw that we were able to work and reduce stigma, and reducing stigma in this case was the stigma and the attitudes that were held by health professionals. This was saying that it is possible to do work that changes the views of health professionals. We saw in many of the projects that through training and development and engagement, we were able to improve the confidence of people to actually work with people with dementia, even in challenging circumstances, and to reduce the likelihood of up-tariffing, of moving to a hospital or other locations, so that people's day-to-day life was less disrupted even when things were challenging. And that confidence, it's not a particularly tangible thing. We don't have a score for it, we don't have a scale for it, but it's something which is very important in the reality of day-to-day care. We saw the Italian project, which I mentioned earlier, saw a significant reduction in hospitalization of people with dementia and an increase in the number of people who were receiving specialist support within the community to enable them to continue to stay there. And they have good data. This is a well-worked-through project which is able to evidence its outcomes. We saw greater inclusion of people living with dementia, and I think one of the exciting things that we saw with the joint action was that, particularly in countries like Greece and Bulgaria and Poland, countries which perhaps have less developed historically dementia strategies, that they took the opportunity of the joint action to make a big step forward. They used the joint action within their local context to leverage political engagement and support for the work that they were doing, and they saw local change as a consequence. Oh. It works better if I do it that way. We could maybe swap the screens around. And we also saw that, and the Norwegian example is a good example of this, the ability to deliver a program at scale, albeit with the caveat that within existing resources, the number of programs of that developed nature are going to be challenging to deliver against the overall size of the workforce. So we were able to see within the period, the 3.5-year periods of the joint action, that we actually delivered things. Things happened in real life that go beyond the publish of a document or a strategy. But the intention behind this was, because that's 30 or 40 projects across Europe, probably not involving more than 100,000 people when we added up. What's the learning? What are we able to take from that? I'm going to identify five or six key messages which I've taken from this, which I think are as important as the evidence in terms of how we move forward. So the first is that foundational education and anti-stigma work is still important, even in more established health and care systems. This was an interesting bit of learning from the work that was taken forward as part of the GP nurse collaboration within France and also within Italy. And I think the reflection that I have on that is that it indicated that even in an area where we had a strong belief that people understood dementia, that there were well-established strategies, that there was real value in continuing to go back and understanding the need to continue to do attitudinal work with health professionals and awareness raising. And so these foundational components of strategy, we need to not imagine that we are now beyond them. They, even in the most advanced systems, they need to be part of our day-to-day approach to how we approach improving dementia care. So we understand that, we're now beyond that, it still requires a lot of work on the ground. So that's my first message. The second is maybe more generic, and it's this idea that things happen when there's a local need or desire for change. So across the area, what we saw, across the actions, what we saw is people becoming engaged in doing things because locally they put their hand up and said, we have something that we think we can do better with, we have something that we can fix, and that was the motivation. It's not enough for something to be in best practice. The fact that we think this is a good thing that other people should do doesn't yet make it a good thing for them to do it. So again, what this I guess gives this gives us a challenge. I guess it means that we need to be persuasive as to why people might want to approach things differently. But the other side of this is, I think we also have to be conscious of taking opportunities to, when people have a need to make change, to be able to offer the best practice. So I guess that's one of the reasons why we don't always see really good ideas spread as quickly as we would want across the system. Things that help people achieve their personal or systemic outcomes are best. So if we can identify, and I guess in my head, one of the things which I think of at this point is clinicians want to be good clinicians. They want to offer high quality care. They want to meet people's needs. They want to do so in a professional way. This is generic. How can we help people do that? With that, one of the components from the French example, the GP nurse collaboration, what was identified within that was continuing evidence of historic ideas of dementia were holding back but also professional roles. The idea that the doctor would take advice from the specialist nurse was a challenging idea. But these are things that we can work on. We can change how people frame their values. And again, the anti-stigma work works in that way. Implementing the same or similar evidence base in different environments will get different outcomes. I think a good example from the joint action on this is the work that was done around residential care. So the implementation of the GRIP work within the Netherlands, which is around training and understanding around BPSD in residential care, very similar to the time work that was being delivered within Norway. but got a very different outcome in terms of uptake. And when we looked into that, what we found was that what in the Netherlands, that there were many other ways in which that particular challenge was being met. So residential care had different systems and processes and protocols to do the thing that the training was meant to do. So when the program came with a new type of training, the question was, well, we can already do this. We already have systems. Why would we now take your best practice? And with the disruption and the change that brings. Whereas in Norway, the time program was a lot more aligned to what was already going on. So it was seen as an evolution, and it worked with where people were rather than as a change. So I think we need to understand that the contextual value, and again, this comes back to the need to meet and help people's needs. As I've said, traditional roles and beliefs are a barrier to improvement. A lot of the work programs that were successful within this identified collaborative approaches between psychologists, nurses, families, carers, and doctors. And in parts of Europe, those are still quite challenging ideas, in that we still haven't got beyond the hierarchy of the doctor being in charge within that context, or the professional versus the familial. And again, those barriers undermine good quality dementia care. Local leadership is generally more important than resources. The overall value of the joint action over 3.5 years involving 40 test sites and 10 or 11 countries was €1.5 million, which sounds like a lot, but it's not really a lot. In that probably covered a number of the meetings, some of the production, and a bit of back office. With that, we still were able to produce a large degree of activity across the place, and we also saw things appearing that we hadn't anticipated. So we saw with the Bulgarian and the Greek work and the Romanian work and the Polish work, additional activity being added simply because people took the opportunity of the joint action to be able to engage and run with it. So I think we need to not underestimate the degree to which people make things happen, as opposed to systems or governments or policymakers. Throughout all of the work, as ever, what we know is properly involving people living with dementia and their families is always a value and leads to outcomes more in line with their wishes. I probably should have started with this, in that this continues to be the message, because at the point when you are in that conversation and in that dialogue, how you understand the problem or what is going on changes and is reframed. But finally, and this is the final message, at the beginning of the joint action, people said you won't be able to get test sites. There won't be enough time to deliver test sites. There won't be any time to evaluate what happened within the test sites. You can do a lot in a short time if you are motivated and engaged. And I'm not tolerant of the idea that change takes time. Change moves very quickly when there is the will and the intention to make change. It's not about resources, it's about leadership, and it's about desire. I'm going to say thank you, but I'm also going to encourage those of you who haven't registered so far that this evening the Joint Action is holding a reception and seminar at the end of the day. It begins at 5:45. Please correct me if I've got that wrong. And each of the work package leads will present in a bit more detail. We'll give the overview. We'll also show some films which have been made, which actually showcase the work on the ground. And should you make it to the end, and there is a reward, we will offer you maybe something to drink and some canapes. So can I encourage all of you to join us this evening? Thank you very much.